Hi, and a very big welcome to everyone. We are here tonight at Connecting the Dots Season 2. Okay, Connecting the Dots is a talk show, and each week we feature different healthcare professionals, patients, or caregivers who will share their insights and experiences. We're basically here to help you to connect the dots. Let me introduce myself. My name is Kai, and I'm a speech therapist volunteer for Aphasia SG, your moderator for tonight. Aphasia SG is the only non-profit organization in Singapore that provides support to people with aphasia and their caregivers. We run free community programs for them, and we are also involved with several outreach and education activities. This month in June, we are celebrating Aphasia Awareness Month, and we have many of these outreach and activities lined up in the days ahead. So stay tuned for, I will tell you a little bit more. And we are live on FB tonight. Hello, everyone. And so please send in your questions, comments, and anything you want to share in the comment section below. And we'll try to get to them along the way. Okay, so we'll start quickly, promptly. Tonight's riveting topic is primary progressive aphasia versus typical aphasia. And you can see on our screen now, we are introducing our esteemed panelists. We have Siew, Elysia, as well as Evelyn. Hi, everyone. And they're all speech therapists working across the different healthcare settings, from acute hospitals to community hospitals, as well as the social services sector. To start the ball rolling, let's talk about our main topic for tonight. We know aphasia is a language impairment that affects the ability to communicate, and it's usually caused by injury to the brain. Before that, shall we let's turn to our first panelist, Siew. Siew, can you share with us, please, what the different types of aphasia are?
Hi everyone. So as we all know, there are mainly 8 types of aphasia. And let me just share. So here you go. So there are 8 types of aphasia, and the experts do consider 3 main factors when determining which kind of aphasia the person have. All right, as you all know, aphasia usually happens to an injury to the left side of the brain, and those factors that we're looking at are: number 1 is fluency. Do they speak smoothly and easily? And does their speech have the right pace, pitch, pronunciation, grammar? Or can they also write without difficulty? So that's about fluency. Then number 2, understanding. How well are they comprehending? Does the person understand what other people are saying? Do they say phrases and sentences that make sense? Or can they also read and understand written words? Right, the next one is repetition. Can they repeat? Okay, does the person have any trouble repeating words, phrases, or complete sentences? So here you can see that this is a pathway of how we identify the types of aphasia. And today we're going to look at these 4. All right, global aphasia, broadcast aphasia, Winnicke's aphasia, and anomic aphasia. That's I guess in our population a lot, we do see this type of aphasia and the terminology used. All right. And so now let's talk about broadcast aphasia, also known as non-fluent aphasia. So in this form of aphasia, speech output is severely reduced and is limited, and mainly is short utterances, words, or a mixture of short phrases. And the vocabulary is really limited. And the formation of sounds by a person with aphasia is often very difficult, laborious, and clumsy. So if you look at message out, that means how are they getting message out is really difficult for them. And it also can be difficult in writing or texting. And what about getting message in? So sometimes this group of people, they may have some difficulty in understanding when others talk, although sometimes they do have this understanding of what people say, or even reading, they may preserve some ability. However, because of their difficulty in speaking, keep stopping, and the effortful of the quality of speech, this term non-fluent is used as well. So the next one is Winnicke's aphasia, is also known as fluent aphasia. So in this form of aphasia, the ability to grasp the meaning of spoken words is really impaired, while the ease of producing connected speech is not much affected. However, the connected speech that's say do not have much meaning. So therefore, because it's so fluent, but lacking of meaning, they are known as fluent aphasia. So getting message out, they may choose the wrong words, or they talk too much. Yeah, really, they talk too much. So, and they may also have difficulty in writing or texting. Yeah, getting message in, however, they are understanding. So they do have a lot of difficulty in understanding what others say. Yeah, so sentences, is also made up of what we call jargon words. Yeah, and reading and writing for this situation are often impaired as well. Now we have two more to go. That is the next one is global aphasia. Many of our patients, sometimes when I see in the hospital, this term global aphasia used. So it simply means it's actually the most severe form of aphasia that is applied to patients who can produce very few recognizable words and understand little to no spoken languages. So spoken language, yeah. So person with global aphasia really, they can neither read or write, and may often be seen immediately after the person who has suffered stroke. So when the brain is damaged very acutely, they have really a lot of difficulty talking as well as understanding what people say. However, with greater brain damage, the severity and this disability can be quite long-lasting. Yeah, depending on how severe the brain is affected. And another form, I would like to draw your attention to another form of aphasia, that's anomic aphasia. So this term is usually applied to people who have very significant word finding difficulties when it comes to nouns and verbs. So as a result of this, their speech, while fluent and in grammatical form, sometimes when they speak, they do use what we call vague circumlocution, or they use a lot of descriptors very vaguely to explain something. And oftentimes they lots of frustration because they can't get the word out. So they understand speech very well, and in most cases their reading understanding is good, but they do have difficulty finding words even in writing as well as in speech. Yeah, so these are the four types that I would like to highlight to our audience today. Yeah.
Thank you, Siew. It was very clear to talk about the overview of the aphasias and the different kinds. We just have a quick look at our FB Live pages. We have about 225 viewers right now. Thank you for tuning us today. We move on, and then we are taking questions as along the way. Yes. Okay, so we're going to hear a little bit now from Evelyn, who will give us around a summary of primary progressive aphasia and how it is diagnosed. Evelyn?
Thanks, Kai. Hi, everyone. Okay, let me just pin myself. Okay. Yeah. Hi, everyone. I'm Evelyn. So I'm also a speech therapist, as Kai mentioned, and I'll be sharing a little bit more about primary progressive aphasia, PPA. And I think it's something that we haven't really been talking so much about because it is quite little known. And I think it is timely that we have this conversation as well. And we will share why later on, yeah? So PPA stands for primary progressive aphasia. And what it is when the language ability of a person becomes very slowly but progressively impaired. And what it is a rare form of dementia. However, based on the clinical definition, right, is that the preservation, of this person's other mental functions. So we're talking about like memory and the ability to actually do activities of daily living, which we call ADLs, are maintained for at least the first 2 years. So, so this might be of interest to our audience, right, when they think about aphasia, and sometimes, they might even say, oh, we have had this question before in our outreach programs where they ask, so what is the difference between aphasia and dementia? So we will address that later on, but we want to then acknowledge that there is a form of dementia called primary progressive aphasia. It is considered a rare form, but what it is not Alzheimer's disease, because when Alzheimer's disease is the most common form of dementia. And what we do know based on literature, is that most persons with PPA, primary progressive aphasia, will actually maintain the ability to take care of themselves. Meaning, as I mentioned earlier, they can still perform activities of daily living. They can still pursue their recreational hobbies, their leisure, favorite leisure activities. And in some cases, they can still remain employed. For example, if they are in a more manual job, which doesn't require them to communicate too much, they could be maybe a dishwasher or cleaner, or maybe some other jobs that don't require them to use the phone or send emails. They could still be doing it. So I want to give an example of a patient that I'm currently seeing for intervention who has PPA, and she has been diagnosed with having aphasia, though the term PPA was never explicitly written in the doctor's memo, but she presents like that. And you know, she's very well. Actually, if you look at her and you speak to her, you may not even know that she actually has PPA, a form of dementia, except that her language, she's not able to really name words. So if you were to show her a mobile phone, for example, she won't be able to say this is a handphone or mobile phone. She doesn't really quite have the word for it, which is like the word finding problem that we have in aphasia. But it's quite amazing how she's very friendly, very jovial, and on weekends, she does her favorite activity, which is to go to her neighborhood to just mingle with neighbors and to go to the hair salon. So yeah, still very much enjoying her life. But definitely, I was called in because the family realized that she has a real, you know, her language function has really deteriorated in the past year. Yeah. So then the question, this begs the next question, which is how do we then tell when a person has PPA, right, versus other kind of dementias, since we already know that dementia is an umbrella term. So there are some diagnostic criteria. Okay. One, okay, so I'm going to read through, but then explain a little bit more. We know that there is an onset of some word finding difficulty. So when we talk about language, right, we always talk about word finding because that's the most apparent in terms of expressive language. But sometimes it's also other things like the syntax and even the usage of grammar may be impaired. So basically, when you think about language, how can a person's language be impaired? So this is how we see it being presented in a person with PPA. You know, they actually may have problems with object naming, word finding, syntax, and even sometimes comprehension of words. The patient that I spoke about earlier, she is Mandarin speaking and interestingly has a lot of tonal errors in her speech. When I can get the context of what she's saying in conversation by and large, but she will make a lot of tonal errors even when she finally gets the word. So this is really how somebody with typical aphasia might present as well, right? And in this case, she also started to have this progression of her language ability being lost. But as mentioned, she actually can still do her daily activities, right? Going around the house, going to the neighborhood. She's well. And that's at least for the first 2 years, according to literature, right? And we also know that this person who has PPA or who's been diagnosed with PPA actually has intact premorbid language function, unless you talk about dyslexia, right? So dyslexia is also a form of language impairment, but it's congenital. But in this case, according to case history, you know, and all that, we know that, oh, this person's premorbid language function was actually not impaired. And we also know that, we also know that this person doesn't have any disinhibition, any major behavioral changes, right? And no loss of memory of recent events, or any serious sort of like sensory motor dysfunction or apathy, which are all, if you are aware of how dementia is, right, like Alzheimer's is, these are all behavioral changes that might occur in somebody with Alzheimer's, but not so much in somebody with PPA, right? Hence, this person within the first 2 years would actually not fulfill any of the diagnosis for dementia typically, except for the language loss. And then moving on, we also know, okay, so ADLs I've said many times already, but the other thing is over time, because it is dementia, other than language, the person will also start to have a deterioration in other functions such as memory. And also you will find that there are some behavioral changes which we have heard being reported by caregivers. So this happens, typically after the 2-year window, we start to see that, but still we will notice that language is still always the most impaired function that deteriorates the fastest. And of course, the other thing that rules out, that tells us is PPA, is when you rule out stroke, brain tumor, brain infection, TBI. So all that is ruled out, when you do a brain scan. So we can then say, okay, this person actually can be diagnosed as having primary progressive aphasia. Yeah. So I hope that helps clear the air a little bit. Yeah. Okay. Yeah.
Thank you, Evelyn. And thank you to our 30+ viewers right now. Very exciting discussion going on in the chat group. Please keep it going. Evelyn, we have a question from Miss Liz Standing coming in from New Zealand. Hello, Liz. Thank you for tuning in all the way from the land of Kiwis. She asked that her mom has been diagnosed with PPA at the age of 80, and that the family has been told that this is unusual, as it's usually diagnosed earlier, and she wants to know whether this is correct in our experience.
Actually, PPA in itself is quite rare, isn't it? I mean, even though I've been a speech therapist for more than a decade, I can actually count the number of patients I've seen with this condition. So I'm going to get everybody to weigh in. I must admit, I have never seen anyone in their 80s with PPA. Yeah. The profiles, if we talk about purely age, is typically about 60s. The ones I've seen, about 60s and 70, 60, the ones, yeah, between late 50s to early 70s. Yeah. How about the rest? I mean, do you want to weigh in on this? Yeah.
Yeah, I was just thinking, yeah, anyway, thanks for the question. I was just thinking, actually, when we talk about things like dementia, we do know that it's usually diagnosed, or rather the common onset is around like 60, 65. I remembered in about 2015, there's actually a recent paper in Singapore that talks about how 1 in 10 people in Singapore above the age of 60 actually can, or rather were diagnosed with dementia. So in terms of the prevalence in Singapore, it's about 10%. So we're just talking about general dementia. So if you think about a population, 10% of them having dementia, and this PPA being like a really rare and a very infrequent subtype. So I would say I wouldn't be surprised to have somebody diagnosed that late, but it's definitely very uncommon. The other thing I can think of is also in terms of the way that dementia is being diagnosed. So I think as a clinician working in a hospital for like many years, it's very common for us to actually see dementia being diagnosed based on exclusion. So the patient don't have this, don't have that. And I think it's also quite common in this part of the world to actually have a dementia diagnosis maybe without or even before having any of like the brain scans to kind of confirm that diagnosis. So I mean, back to the question. So is it possible? Is it common? Is it rare? Is it wrong? I wouldn't say it's wrong or right, but I would say it's possible. And I guess later on, as we talk a little bit more, I would say what matters is actually what we can do to actually support this person with PPA or dementia or aphasia, for the matter. Yeah.
Yeah. We have a question from from Charlene, who maybe we can speak. She wants to Evelyn to maybe elaborate a little bit more. You mentioned that if there is a brain tumor or an infection, etc., then it's automatically dementia and not PPA. And she wants to know a little bit about the treatment and then how it's like, and are they similar for both types of patients? Maybe you take the first part of the question first.
Okay, I think so. The question is, okay, I think
if the brain tumor and infection bit, is it automatically classified as dementia?
Okay, I think there's some miscommunication there. So in the so in the diagnosis criteria, we're saying that for a person to actually be diagnosed with PPA, typically they would not have had any other forms of brain injury or damage. Yeah. And I think later on, Hui Chu will share a little bit more about other types of dementias. So then, it is true that if you have had, a stroke or another kind of brain injury, it predisposes you to certain types of dementia, for example, vascular dementia. But in this case, I'm talking about the diagnostic criteria for PPA. So we're saying that this person who actually is being diagnosed with PPA, right, actually doesn't have other kind of neuropathology. They actually have not had a stroke or a brain tumor before. Yeah. So I hope that clarifies. Yeah.
Yep. Yeah. That's very good. We're going to segue now back to Huaisi. Huaisi, you mentioned just now while answering the question some of the differences about dementia and aphasia. Let's hear from you now. What are the differences between these two conditions?
Right. So I think without being too overwhelming, because I think these are two very big topics. What I want to share is actually maybe just from a very basic layman's point of view. If we think about what we know about dementia, I like to tell my patients, the caregivers, what you see on TV is probably not that far off, but the kind of TV dementia that you see is probably closer to what we call Alzheimer's dementia. So if you think about it, dementia, what we do know, there are some memory issues, there are some changes to the way the person process information. So I'll come from the point of view of like how the brain works. So what's the difference? If you think about dementia, this kind of memory changes, brain changes, it is not part of normal aging. A common misconception is that, oh, well, I mean, if I grow old, I tend to get a little bit forgetful, but to be forgetful to that kind of extent, to be forgetful to the point where you so-called forget whether you have taken your breakfast, whether you have showered. So that is actually not part of normal aging. So in terms of the changes that happens in your brain, memory is the one that we are very, very familiar with. When we talk about aphasia, it's not dementia per se, because the changes to the brain, what is actually affected more directly is more the ability to use language, the ability to process language. So if you think about the differences, similarities, there's some brain changes. One of the key or very obvious difference is that when we talk about dementia, that change is usually not sudden. You will not wake up the next day having dementia, for example. So it's usually very gradual, and I think partly because of that, it's probably a little bit difficult to tease out. So that's why just now when Eve talked about this very, very particular, this very rare form of dementia called PPA, initially when people first discovered it, I think back in 1985 or something, yeah, they were actually saying something like, oh, it may actually take 2 years before that kind of language change to show up. So of course things have changed since then. But so when we talk about dementia, the kind of brain changes, the kind of effects that you get, it pertains more to do with how the individual live their life. And I think memory, again, like is the one that we always see. Of course, partly because of that, sometimes the way we interact with the world may change. As a result, the behavior may change as well. Whereas when we talk about aphasia, we are talking about how this changes to language processing, how I understand language, how I actually use language, be it writing or speaking. The way I process language in this way, it can change. And again, because of that, I may have a certain set of behaviors that may actually be adjusted as a result of that. Of course, finally, I think just now I mentioned something about how there's this recent study, well, not that recent, and that talks about the prevalence of dementia in Singapore. But when we talk about aphasia, because it can be like a sudden event, it can be like after a stroke or maybe like a physical head injury. It can really happen to anyone. Dementia, there is a subtype called early onset dementia. That usually happens maybe in like your 40s, 50s, or even 30s sometimes. But when we talk about aphasia, literally anyone can have aphasia. And what's debilitating about it is that you may actually be interacting with someone with aphasia and not realize that, because it is really that invisible. I think sometimes what we call an invisible disease. We have had stories of patients with aphasia just in the streets buying food, and because of their challenges in communications, the vendors may not realize, so they get hurried away. Sometimes it's easier for them to communicate non-verbally and point, and the hawker or the seller may end up telling them, don't point to me, just tell me what you want, just say it. But actually that's the challenge in itself. Yeah, so when we talk about these two conditions, so a person with PPA, primary progressive aphasia, you can say that this person has a little bit of both. From a research classification point of view, it's actually classified as a kind of dementia. Just I think Eve mentioned a little bit about Alzheimer's, a little bit about vascular. There's actually a third type called frontotemporal dementia. And within this third type, a very, very rare form of frontotemporal dementia, that is where they actually classify this primary progressive aphasia. I mentioned a lot about language. So as we know, language, there is that understanding component, there is that expressive component. Siew just now has also given you all a very nice brief summary of the various types of aphasia. So even within this category of primary progressive aphasia, there are further subdivisions to what kind of PPA that the patient may have. For example, I think the more common ones within this very rare, I say common, but actually it's very rare. So within this very rare subtype, you have like what they call the semantic variant, meaning they can be very fluent, but there's some kind of language breakdown within. Or you can have the agrammatic one. So that will be closer to what I think just now Siew mentioned, the Broca's type of aphasia. And of course, finally, the rarest of them all in terms of PPA, you may have somebody who actually appears kind of okay, but have very specific deficits, very specific issues with like repetition of sentences and phrases and so on. Yeah. So again, why we want to emphasize this point about rareness is because it's really something that doesn't come up very often. And in a way, why are we having this conversation today is, of course, because of the recent announcement by Bruce Willis, where I think his team actually released this statement, or I think his daughter actually released this statement saying that our favorite actor, Bruce, has aphasia, and it is neurodegenerative, and yeah, please send him your regards and then give me your thoughts. So when we talk about aphasia, it's actually not degenerative, and most patients do recover to a certain extent. So when he released this statement about how he had aphasia and it is actually progressively declining, changing. So I think there are a lot of experts weighing in and chiming in and talking about what might they be talking about, and that's when this PPA thing came about. So as we dig deep, as we share a little bit more, why is it classified under like this dementia category? Is because for patients who have this primary progressive aphasia, they do eventually get the kind of dementia symptoms as well. They do experience that kind of memory loss that we see so common on TV and what we do know about dementia. In terms of the brain changes, we do see, or rather the researchers, the papers do see quite a bit of changes to the frontal temporal regions of the brain. That's very common with this subtype of dementia. So all in all, I hope we're not confusing anyone or we're not making things more complicated. Life is not easy, but in this case, this PPA, the person with PPA, it will be very challenging because they will start off having a lot of aphasia symptoms and then subsequently having a lot of the dementia kind of like challenges setting in and affecting that person as well. Yeah. So yeah, Kai, who do we have next?
Thanks.
Yeah,
Quite so maybe you could
Yeah, I'm going to, at this point, sorry, just draw a Venn diagram. As you said, we hope we're not confusing anyone. And I think a Venn diagram is very timely so that we can just summarize, what we have been talking about. So I'm just going to draw, okay, as best as I can, 2 circles. Y'all help to fill in. I think y'all know what I'm drawing, right? So we have this. Wow, 2. Really. Okay,
and then one of those memes.
Yeah, so yeah, this is going to be one of those, right? So this is aphasia, right? And then we have here, this is, of course, over here we have dementia, and right in the middle we have this sweet spot, which is, right, PPA, right? And then we just want to also say that this, okay, so with aphasia, it's acute, it's sudden loss, okay? So we talk about, right, we always say stroke, then TBI, right? And then tumor, etc. But then dementia is gradual, okay, gradual, okay.
I mean, there are also a lot of overlaps, right? Because when you talk about tumor, of course, it's not that sudden as well.
Yeah. And then, of course, remember, we always stress this point about this is language loss, but not intellectual loss, right? Not intellectual problem, right? Because what now the confusing part might be, then how come we are saying that this person has dementia? Yeah, but then with this one, a lot of it is memory loss, and then also inability to do ADLs,
which is the cognition part of things.
Right. Yeah. So
executive function. Yeah.
I mean, this is really summary because it can be very confusing, and if you're confused, don't worry, it is confusing even for some healthcare professionals, okay? So don't worry too much about it. Yeah, we just hope to shed some light on this, because as speech therapists, we see these populations of patients a lot. Yeah, and we understand the nuances, but maybe another person who doesn't work so closely with this neuro population may not fully comprehend. So we hope this diagram helps a little bit. Yeah. Sorry.
Thank you. Can we go back to that the Venn diagram?
Oh yeah, for sure. Yeah.
Yeah, it's helping to answer one of the questions that we have from Miss Wong. She's wondering whether if is PPA hereditary, and if her loved one has it, will she has a high chance of getting it? So Ms. Wong, I think you can see from the Venn diagram that these conditions are not hereditary. Just because your family has it doesn't mean you will get it. So I hope that answers that question. We have another one. Maybe, Siew, just before we move on to our last panelist, Elysia, I hope you can hang on there, Elysia. But the questions are coming in quick and fast. We have about 35 odd viewers right now. Hello, everyone who's just joined us. Miss Femme Forte would like to know if aphasia can lead to behavioral changes. They would like to hear from the panelists, what are these behavioral changes that you're talking about? Do they become more quiet, or do they become loud and disinhibited, or do they become a little bit more childish, or any tips that you can share?
So I'm just going to say, I think, and everybody, please share your thoughts, but so when we talk about pure aphasia, right? So once again, we're just talking about the loss of language. So I'm gonna use this example that I say many times. So if you've heard it before, please bear with me, which is, imagine now you are in a foreign country but unable to speak the language, and you have to actually order food. So the idea is, if you are actually using a language, you are speaking English, but this person is actually speaking to you in Russian. And then, the menu is in Russian. Okay, maybe not the best example because they're at war right now, but you know what I mean, right? And it must be extremely frustrating, because the language that is going in is not something that you can access. The text that you're reading is not something that you can read, and you cannot speak the language. So will it cause you to be frustrated?
Okay, I think Eve is breaking up, is it?
Yeah, she's back.
Okay,
she's
sorry.
back, yes.
Yeah, I think it's my Wi-Fi.
You were in Russia, Evelyn. You were in Russia.
Yeah, and you're talking about, how frustrating it will be, right? If we can't order food, we can't say it. Yeah.
So what I was saying is, if I think for most people, if we say, hey, if you're unable to access the language, will you be frustrated? I think it will be a resounding yes. And that's the part where we talk about the behavioral changes that happen. So when somebody is diagnosed purely with aphasia, right, and it is not a cognitive issue, sometimes the changes that happen in behavior is really a manifestation of the frustration or the isolation they feel because of the language impairment. Does it make sense?
Yeah.
Yeah. To top it up is, Evelyn gave a very good example to any one of us, right? Because language is the best way for us to communicate our feelings, emotions, thoughts. And sure enough, with aphasia, they lost this. And there's a research that actually show that about 93% of people with aphasia actually have depression within the first, I think, if I'm not mistaken, it's the first 3 to 6 months. Yeah. So all this is the exhibition of like behavioral changes. Frustration is a very clear cut, and sometimes why they're more quiet, because people who don't understand the condition, they keep asking, like, can you remember, or can you I have this client who family, of course they're trying to help, but they kept answering for that person. So then the person learned to just be quiet, because someone will always answer for them. So if you want to talk about behavior change, so these are some of the things that a person post-aphasia may face and show up.
Likewise, I remember one of my patients saying, and sometimes don't forget, right, like how the person, the loved one is with a family member is very different from how he will behave with a therapist or
totally
clinic. So in clinic, this patient actually told me, you know why I don't talk at home? But because sometimes the family will say, he will only talk when he comes here because he sees you in therapy, but at home he doesn't talk. And then he actually expressed that at home he feels very frustrated because he's constantly being tested. So for example, he is being served lunch, right? And maybe lunch is porridge, right? And then whoever is serving him the lunch, whether it's a wife or a daughter, will say, what is this? What is this? And he's like, he knows what it is, but remember he has aphasia, so he doesn't have the word porridge for it, but he knows what it is. So it's a bit different. In clinic, why we can test is because we are in that role of a clinician. We are supposed to be here to test, to challenge you. But as a family member, I think the dynamics are different. As a family member, perhaps it's taking more of a loving role, a supportive role. Perhaps the patient is like, in hospital and clinic, you come and test me, fine, I'm ready to be tested. But at home, I really just want to be supported. So
I mean, to be honest, like we don't test patients every session, right?
We don't.
So just disclaimer, as speech therapists, we don't test you all the time. We're nice people, we chat with you. And I think one of the I won't say hallmarks, but one of the very common therapy or treatment approaches or intervention that we do is actually less about testing, but really more about that kind of supporting that individual, a lot of times working with their communication partners to actually teach them how to actually interact with this person with aphasia without stressing everybody out, so to speak. And I think when we talk about the behavior changes, support congratulations. I was wondering whether we have time for that. And I think we talk about behavior, I would like to see in a positive light, in a sense that when we talk about aphasia, we talk about a recovery, we talk about changes, they do get better over time. And I find anecdotally, it is like a cycle. Siew talk about how a lot of them may get depressed, and if you think about it in a different way, that's actually a good thing. In that sense that they are having that kind of awareness. You imagine yourself falling really, really ill at the start, maybe like a high fever, you're probably delirious, you probably have no idea what's going on, everything is just so fuzzy, I'm very ill, just leave me alone, just let me sleep. As you recover, you start to regain that consciousness, you start to regain that awareness. And I think sometimes for a person with aphasia, when that awareness sets in initially, it can be quite confronting and quite daunting. And that's when we see a lot of the kind of behavioral changes, in the sense that they may actually clam up, they may get frustrated, they may get more confused. And I see that as a positive, because to me, that means the brain is evolving. We know the brain is plastic, there's changes, the neurons are recovering. So I see it as a journey. And I think whenever there are changes like that, as long as we are able to just walk with them along the way and give them the support, I think that's when they will change further. And I think hopefully we can also help them along the way to get better.
Thank you. Thank you, Hoyte. Very enlightening discussion so far. We have more and more questions. I just want to address something, one thing, because it leads us next to our next panelist. Kimberly is asking, it must be quite difficult to diagnose PPA since there's not much behavioral differences in the first 2 years. And she would like to know how PPA is diagnosed. And I think Elysia, our last panelist, is going to take us through that. Elysia, all yours.
Hi everyone, I'm Elysia. It was a very, very good discussion, and I'm sorry I have to talk about assessment right now. But I feel like intervention and treatment is more interesting. Okay, just gonna share screen. Okay, so when we receive a referral for someone with PPA or aphasia, the first thing we do as speech therapists is we're gonna find out how much are they understanding, how much of the message is coming in, and how much are they able to express themselves, how much of the message is coming out. So we have these tools that we see mostly from the West, and we have it in Singapore. So Western Aphasia Battery, Boston Naming Test, Comprehensive Aphasia Test, and the CAL. Very, very common assessments, but we do have some issues when we come to use them in our local population. So one of the examples is a picture like this. We are looking at, are they able to name it? A lot of times, if they're not able to answer, is it because they don't understand what the picture is about, because they're not familiar with it? Or is it because they really can't find the words? So sometimes when we use batteries that come from the West, it doesn't tell us very much. So it just tells us that they don't know what it is. So this example is like of the HDB. If we can use something which is more local context, then it's more easy for us to find out if they actually know what this is, and if they know what it's called, or they know what it is, but they simply can't find the word. Another example for this is, so we are looking, the picture on the left is when we are finding out if they understand that the hand goes with the glove. So we're looking at semantics. But in Singapore, we are on the tropics, in the equator. We have no need for gloves except for gardening. So sometimes we need to think about other ways that we can access this semantic system and find things that are more culturally appropriate. This is the very well-known Boston Naming Test picture cookie, TEF. And the patient is supposed to tell us what's happening and what's wrong in the picture. So again, it is very clear to us that what's wrong and what's happening, but sometimes, we get answers like, oh, they're wearing shoes in the house. How do we score that? That's not in the scoring booklet. So again, culturally, it is inappropriate. So what we use is many different kinds of pictures that are known to the local population here, pictures of food and common items, and we can use these to informally assess whether they are able to understand what the picture is about. Are they able to tell us what it is? This is an example from our local breakfast. So we have many different languages in Singapore, and we're multilingual. Cup of coffee, it can be called coffee, it can be called kopi, it can be called cafe. So when the patient then replies us with whatever they call the drink, we still would say, yes, they are able to understand and they're able to tell us what it is, even though they may be English speaking, but they reply in a Chinese word. It's okay, it's fine. So bread as well, there's bread, there's roti, and then there's mian bao. If a Chinese person says roti, that's fine to us as well. So there's many different languages and words that people use for items here. And it's not easy to then use a very formal Western battery to assess. So that brings us more to like the discussion of the intervention, which is the most interesting part. So people with dementia and PPA plus or versus people with aphasia, how do we then treat it? And what's the point of assessing? So the point of assessment is first to find out the severity of their deficits. But someone with mild aphasia or mild PPA can have very, very drastic impacts on their lives versus someone who has a severe aphasia as diagnosed by the speech therapist, but they may be fine. So it really doesn't matter, at the end of the day, it doesn't matter how severe or how mild it is, but how the person accepts it and how they then go about their lives with this condition. Okay. That's all for my slides.
Thank you, Elysia. That was a good overview of the diagnostic process, and I think it gave us a little bit more insight into the challenges that face our local population for both the healthcare professionals as well as our patients. We want to look again at our comment section. It's very happening right now, and I think rounding back around to the topic on interventions and how do we support patients with PPA or aphasia. Miss Rowena Heng, she would like to know, what do we do to support family members who have aphasia? And I think it's time for us to bring up our ace in our card and we talk about a bit more about supported conversations. Any of our panelists would like to take that discussion?
I will just share the slides, and I think it's also a nice like overview to what Elysia shared. So you know, and you can look it up. So this is an approach that was developed by the Aphasia Institute in Toronto, Canada. In Singapore, we do provide training. Get in touch with us if you're interested to learn more about supported conversation for adults with aphasia. In fact, all our volunteers who actually come through the Aphasia SG door, we do give them a short training, you know, so that a crash course of sorts, so that everybody actually understands what aphasia is. That's one. And then secondly, also to know what are the techniques that we can use to actually help someone. So I think the challenge always is in thinking about medical condition. I think it's a bit of this mindset about, okay, this person has a condition, so the onus is now on this person to improve. In this case, with aphasia, we're saying, okay, now you have problems with your language. You cannot really express yourself very well. You cannot maybe you cannot find the words. So the person will also want to improve, right? Certainly so. But while that is happening, don't forget this person actually has had a brain injury. So it's really challenging and difficult for the person with the brain injury to do all the hard work. As the family member and as a community around this person, we can do some of the lifting also to support them. When we learn techniques that we can help to make this person feel better as they are trying to communicate with us, it really changes everything, right? And I think for anyone who has actually participated in our activities, you know that we are all about going beyond words, right? Because we are not too hung up on the actual words that are used. It doesn't matter how fluent you are. It doesn't matter, to us. You don't have to be very fluent, very eloquent, but what matters is you are trying to communicate, and we appreciate that. And I think at the end of the day, that's what matters, right? Simple strategies like, when I say simple strategies, because it's not rocket science, right? So caregivers who are listening in, just try maybe some things like just slowing down and you know, giving the person more time to respond and using visuals, right? So you saw Alicia's slides just now, some pictures, you know, it could be things like pulling out your family photos, you know, showing some, instead of just asking questions, you know, with words, perhaps using some gestures or using some objects that you have around you to facilitate that conversation. So things like that. Yeah,
I think even if it's like, you know, it's a change for the person with aphasia or with PPA, it's also a change for family.
Oh, absolutely.
So
right.
everybody has to learn to adjust and, you know, find the best way to make it enjoyable.
Yeah. I think at the end of the day, it is when we talk about typical aphasia, as we put it, so the one that happens very suddenly, very acutely, it is devastating because it happens overnight, and nobody is ready for it, right? And because of that, I think it does require a lot of perseverance, a lot of courage on the whole family's part. So we're not just looking at the person who has aphasia, but everyone around it who is living with the condition. Yeah. So
exactly.
yeah.
Having said that, right, actually, we always think about, aphasia, the patient is the one that needs therapy. But the fact is that therapy is not only for the patient, but it's also for the family to have that mindset shift. Communication will be different. And how we need to continuously find ways to understand our loved ones, and therapy is just not for them. It's in fact for the whole family. And how I also talk about functional, right? In therapy, we just don't test and ask naming for the sake of naming, right? It's about the function. How can we add value in a conversation rather than we just ask, what is this? Or who am I? I think all of you would know that, family members sometimes out of goodwill, we just ask, who am I? Can you tell me who am I? So that kind of question sometimes may not add value, right? Yeah.
Yeah. I just want to look and highlight a comment that was given by Jeannie in our section. She's just sharing some strategies of how patients at home can be supported by their families. She's saying that as communication partners, it's extremely important to acknowledge and reveal the competence of the person with aphasia by verifying, understanding, provide choices, encouraging multimodal communication using body language, writing simply by being patient and being there for your loved ones. That seems to be the key success factor with anybody trying to cope with aphasia in a home setting. So that's all the questions that we have. Anybody has any of our panelists have any summarizing comments or anything to share and highlight?
I was just browsing very quickly about some of the things that came up in the chat. And I think I saw a few questions about like, oh, I really want to learn how to do this. I want to know how to support. I think actually to a certain extent, we all know what to do. It's about what should we do more of or less of. So I think if there's something really, really easy or something to remember, I would say maybe what you need to do is to forget about being right. Don't be too caught up or too concerned about trying to get the message across, but rather just enjoy that interaction. Yeah, because a lot of times when I speak to my patients or I won't say caregivers, when I speak to my patients, sometimes the caregivers are very impressed because I seem to know what the patients are saying. And then that's when I tell them I actually don't. Half the time I'm just making things up as I go along, or you take on certain keywords. I think acknowledging is a very powerful thing. So sometimes when you're lost for words, I think it's okay to acknowledge that you really don't know what they're saying. Sometimes it's okay to acknowledge that breakdown. So I think as long as you're able to keep that conversation going, even if it's something that may not be right, but I think it's okay. And I think the person with aphasia will appreciate that, that patience and that turn taking and that interaction. End of the day, I think we're all very social. So I think they do understand and they do appreciate that support that you're going. Yeah.
Yeah. I think it's all about having good vibes lah. Yeah, so I think the summary just now by Jeannie, whom I'm sure is a speech therapist.
Yes, I think so.
Yeah.
Because that really is the absolute summary for supported conversation. So I'm not sure whether it is intuitive, but what I do know is when we want to go into supporting someone with aphasia, I mean, we must have this mindset that this person has a language impairment, but then is actually able to intellectually there and would really love to have a conversation with you. So I think that kind of mindset shift, right, and a lot of trial and error, just being creative makes a whole lot of difference. Because obviously, if I were to put myself in the shoes of someone, and I don't think any of us can really imagine what it's like to have aphasia, but let's say I'm overseas right now, right, and somebody who doesn't know my language is trying to actually have a conversation with me despite the language differences, I would be so appreciative. Yeah. So I think just that makes a whole lot of difference. Yeah. I think there is this one point I wanted to make about, I think earlier on, because we talked about dementia, So I think if anybody is just curious about where to get support for dementia, there are places that you can go. This is not aphasia, but dementia, right? This is a really, really good resource hub. Okay. So if you have a loved one who has dementia, look it up. There's a lot of resources on dementia online. Actually, there are a lot more local resources on dementia than aphasia. So this is a good hub. Look it up. Yeah. But hopefully, yeah.
I mean, hopefully this is a good opportunity to kind of expose everyone to like the two very big topics. Like I said, I mean, you keep seeing dementia on TV, sometimes rightly, wrongly represented. But if I'm a script writer and I'm trying to write a story about aphasia, I don't know where I'm going to start, because like what we just said, it's invisible. How do you show this person and how do you show their challenges? Because somebody might think, oh, is that person having an intellectual disability, you know, or is that person having dementia? So it is so complex and so covert. And I hope that this little sharing we have today kind of like gives people a little bit more insight and an understanding. These are two very big fields, and just so happen they kind of overlap this very, very narrow point. Yeah.
I mean, at the end of the day, somebody who has aphasia has the mental capacity to make decisions, and
That's right.
Yeah, so that's really it. That's one takeaway. That's what we want to say. Yeah, and even if someone is diagnosed with PPA, don't write them off. There are ways to actually intervene, but the intervention may not be your typical impairment-based intervention where we're talking about improvement of function. Yeah. So yeah, great. Yeah, Kai, do you have anything to share about our special month?
No, we have a couple of series of events that we want to share. I just wanted to close off the session with acknowledging all our lovely viewers. Thank you very much for tuning in for the past hour. The questions and the comments coming in have been very enlightening, and you know, everybody is very participative and engaged in the session. And thanks to our panelists also. Thank you for sharing all that you have shared. We've heard about the different types of aphasia, the differences between PPA and the typical aphasia, and we even threw in a lot of buffs from dementia as well as the diagnostic process. And we know that they can cause different difficulties in each individual, and we cannot underestimate the devastating effect any one of these conditions can have on the person and their family. So we are very happy and proud to be part of Aphasia SG, who's bringing forward all of these awareness and outreach programs, as well as support programs for people with aphasia and their families. We want to call out Serene, as well as all our question askers, Ginny, Femforte, Rowena, and I'm sorry if I've missed out anybody else. Trying to go back to the chat. The chat is very happening. Okay, so can we have the I just want to give you we wanted to show some of the other events that are happening this month, organized by us. We have the Choose Your Own Adventure is back by popular demand. That's happening on the 12th of June. And we also have Karen, our PT, will be sharing all about neuro rehab and physiotherapy. So please tune in on the 14th on a Tuesday. And then for our next Connecting the Dot, we have a special talk on mental health and total wellness by Mr. Jonathan Quek, who's a co-founder of Total Wellness Initiative. We're going to talk about some coping strategies and outlets for our mental health journey. That's happening on the 16th. And last but not least, we have a very exciting human library session with Ms. Lim Hai Yen. I think if you've heard of her, she's also an award-winning playwright, director, writer, and the artistic director of etc. As well as she has had a stroke, and then she's going to be sharing about her own aphasia journey. And that's happening on the 19th of June. We also have, very excitingly, the man who inspired a lot of this month's activities, Mr. Bruce Willis, and it's a movie night with him and his aphasia. We're going to be discussing a little bit about what his experiences are. That's happening on the last Thursday in June on the 23rd, and we hope to see a lot of you there.
Kai, you better clarify. Bruce Willis is not appearing. Okay? People think Bruce Willis is actually coming to our.
Isn't he? we're still in talks with his agent, so we'll see. We'll update that very quickly. Everybody, please head on over to our website, aphasia.sg, or even on our Facebook page right now. Like us, follow us, send us hearts, send us stars, and whatever it is that we send nowadays on the social media. Follow us to keep abreast with all of our activities, and we would love to see you in real life some days at one of our chit chat cafe sessions, or any of the online events that we have this month.
Yeah, so we have one more. If you can see the slides, how to communicate better with person with neurological conditions. So this is the one that we've been talking about. Do sign up. It's on the 26th of June. Yeah, and it's free for everyone to come and know more how we can continue to support and create an inclusive Singapore for people with aphasia or other neurological condition. Yeah.
Okay, if that is
Thanks so much, audience, and I think it has been such an invigorating conversation. We invite anyone who has questions to reach out to us, via our social media, email us. Yeah, thank you all so much for tuning in. Thanks, Kai. Thanks, Misha.
Thank you.
Thanks,
everybody.
Thank you, everyone.
Good night.
Good night.